Welcome to this episode of Vet Candy's Rapid Rounds. I'm Dr. Jenifer Chatfield.
And I'm Dr. Courtney.
And we're going to discuss the case of the Crusty Pomeranian. We're going to be talking about the case of the Crusty Pomeranian. But as a quick reminder, Rapid Rounds is an interactive case discussion where we want you to be ready with that pause button and use it liberally, but appropriately, to stop, have a moment to think, what would you do? And pick from the choices we offer you, because sometimes in life, the answers are multiple choice. Okay, well, let's get right to it, shall we, Dr. Courtney?
Today, we're going to be talking all about wound care. And the first up to bat is a Great Dane by the name of Zelda. Zelda is 5-year-old female spayed Great Dane who has an 8-month history of a mass on her toe. And this mass is huge. Take a look at these pictures, Jen. Yeah, pretty big, right?
Oof.
Yeah, exactly.
Oof, that did not happen overnight.
Yeah, I was thinking maybe like it happened over the weekend, right? No, but unfortunately for Zelda, she had this toe mass and it grew. It grew pretty big. It started out pretty small, but as it progressed proximally or sort of towards her carpus, it actually started to encroach upon the metacarpal phalangeal joint, or that intersection. Then it started to get wide in sort of the medial-lateral direction and encompass both digit 2 and digit 4. At least it touched it. But the center of mass, the center of this sort of tumor, this neoplasm, was right on digit number 3. So after taking a look at some of the primary veterinarian's records, on the cytology, they suspected that it was a mesenchymal cell origin, or a suspect soft tissue sarcoma. Exactly. No good.
Oh, there's some words I know.
Yeah,
there's some words I
exactly.
know, Dr. Courtney, outside of veterinary school. Soft tissue sarcoma. Mesenchymal, not so much.
So upon seeing this mass, it had 3 spots of ulceration, so it was like breaking through the skin. And a variety of staging diagnostics were offered to that family, including a punch biopsy, including cross-sectional imaging like a CT scan, to really determine the margins of the mass, a sentinel lymph node aspirate, as long as a thoracic radiograph metastasis check, regular blood work, baseline lab work, those sorts of things. After all those staging diagnostics were offered to them, they elected for a punch biopsy. This is where we were able to conclude and definitively diagnose that this mass was truly a soft tissue sarcoma.
At this point, the mass has been poked and punched, is that right?
Poked and punched, and finally we have a definitive diagnosis. It's grade 1 soft tissue sarcoma, which leaves that family in an interesting predicament, because because to remove that entire mass, it might require something more radical, like a radical resection, including a digital amputation or possibly a partial foot amputation. Or if they wanted something marginal, they'd have to get within the capsule of the tumor, which could increase its chances for regrowth. So it left them in an interesting quandary. After they made their decision, they elected for an intralesional resection, and that's different than a marginal, wide, or radical resection. They wanted this tumor off and closed. But here's the problem. Once it was removed, there's not a lot of skin there to close it. So it had to be left open to heal by second intention.
I guess the real issue that we're facing here is that what we see a lot of times in distal limb surgeries, which is there's just not enough dog, right? Not enough. What is your favorite phrase? There's just not enough real estate left to close that. Is that right?
Exactly. There's just not enough skin there. And even with the most advanced reconstructive skin techniques, so sort of tension relieving techniques, there's just simply not enough skin because that mass was so huge.
So you're going to leave it open.
It was left open. Surgery was performed, mass was gone, intralesional excision was performed. Now the mass is gone, but now there's a big gaping area where there's no skin left to close. Let's take a look at these pictures immediately post-op. Now, that's pretty intense, right?
That's pretty gnarly. And I'm wondering if the surgery's half price because you only opened it and didn't close it. No?
Definitely no half price. But I will say this, this was absolutely the best thing for Zelda because that mask was starting to push on certain structures and it was really uncomfortable. Now with this mask off, she's gonna feel a heck of a lot better. But now we have to get this wound healed and closed. So Jen, what would be your first steps when treating this wound?
I have a very good idea of what I would do.
Okay.
And Courtney, I know you know what you would do. But what's most important is what are you going to do at home? So take a minute, use that pause button, and look at these 4 choices.
Okay, so did you make your choices? I hope you made the right choice. Jen, what were you thinking?
Great Dane, Bigfoot, I'm gonna run and hide. However, since I can't do that because I am put on my big girl pants today and I'm a doctor, I'm probably gonna lavage the wound. Yes, lavage.
Yeah, I'd say you're spot on, and that's what I would do too. I think it's important to emphasize that all wounds need appropriate lavage, whether or not they're clean or contaminated. Sort of lavage just helps to remove debris, bacteria, exudate, particularly if there's a film, or let's say that there's a previous wound dressing that you've already applied. It just removes that residual wound dressing. So I think it just helps to rehydrate the wound and provide a much more conducive environment for wound healing. So here's the second question though. What if that wound wasn't immediately post-op? What if that wound was contaminated? What would you do then?
Lavage it with, what is it, the saline system? Because I don't want to use super high pressure, right? Am I remembering that right from school, Dr. Courtney?
You're spot on. I would do the same exact thing. Use a 1 liter bag connected to a pressure system and kind of get that pressure up to 300 milligrams of mercury and then attach either a 16 to 22 gauge needle because the goal is to achieve a PSI of about 7 to 8. Now, going too high, pressures that are too high can actually force debris and bacteria into the tissue or sort of dissect into the subcutaneous space. So you don't want to do it too high and too low, although it has been shown that even low pressure could actually get rid of some bacterial contamination. It's ideal to get that goal somewhere between 7 to 8 PSI on a contaminated wound. So you're spot on. That's exactly what I would do as well.
For our colleagues, like myself, who frequently find ourselves with a patient that is laid out on the back of a golf cart inside of a barn rather than in a referral practice. And if we're going to have to irrigate a wound such as that that's visibly grossly contaminated, is the garden hose a bad choice?
You know what they found between sterile saline and tap water, not really a big difference there. They can still act to remove debris, remove bacteria, remove exudates, whether it's between sterile saline and tap water. Now, the pressure system, now that's going to be a little bit more variable. If you can invest in some syringes, get a 35 ml syringe, attach a 22 gauge needle, and you could still fill it with tap water. So at least you have an alternative when it comes to that.
I think I could invest in some syringes, Dr. Courtney, okay? I think I could do that.
All right, well, fantastic. Now that we know what you would do as your first step with that wound, then if they threw you a curveball, it was a contaminated wound. Now, let's find out, Jen, we all want to know, what are your topicals of choice when dealing with that wound immediately post-op?
Once again, use the pause button and have a look at these choices.
So Jen, of those choices, which one did you choose?
Oh, it was tough for me, but not really. Even though I think you've blown up my choice of silver sulfadiazine, I'm still sticking with it, man. I'm committed.
I admire that commitment.
Yeah. However, I'm hearing a big butt coming. Are you guys hearing that at home? A big butt coming? Tell me, lay it on me.
Well, listen, the reality is I'm a big fan of medical grade honey and a nanoparticle silver impregnated wound matrix. And I love medical grade honey because it lowers the pH, which is ideal for wound healing. It has antibacterial properties through this molecule called methylglyoxal. And then most importantly, it actually prevents biofilm formation. But you know what also prevents biofilm formation? nanoparticle silver impregnated wound matrix. This, what's really interesting about it is you can cut it into size. So really irregular wounds or odd shaped wounds, you can cut it to size and it will actually adhere to the wound. And what's cool is it sort of prevents matrix metalloproteinases, it prevents bacteria, biofilm, and it adheres to that wound. So also has some absorptive capacity as well. So I think, in my opinion, I think you could go with medical grade honey or the nanoparticle silver impregnated wound matrix. But what's cool is you can use them together.
What? Wait a minute. That's the double whammy. That's the double whammy for the wound, right? You're gonna really kick it up a notch.
Well, let me give you another whammy. Let's go to day 5, immediately post-op. Check out this picture. Yeah, it's pretty intense, right? Well, it's awesome. It's awesome because, and here's the deal, it's awesome because granulation tissue has really taken over this wound, which is exactly what we want. We want the ideal environment for this wound to heal. And when you see healing, you know granulation tissue. So let me give you another question. At this stage, when you see that amount of granulation tissue, what would be your topical of choice right now?
Everyone press that pause button and have a gander at these choices.
So, Jen, after taking a look at those options, now we're at day 5. We've got a lot of granulation tissue. Which one of those 4 choices would you pick?
Okay, well, I mean, I'm kind of a fool right now if I'm not picking the silver impregnated. Yes, that one. Like, I don't want SSD because you've said that well, it's good for some things. It's not like the silver bullet. Wait, do you guys see what I did there? It's not the silver bullet. However, that silver impregnated one, I think, may mitigate some of those issues. Yes?
Yes, I think you could really make a strong argument for C or D. My preference would be D, not only because that silver impregnated wound matrix will actually adhere to the wound, it's also transparent. You can see through it, see what's happening under that wound. And of course, like we mentioned, it prevents biofilm formation, has antibacterial properties, and of course, particularly against these more resistant forms, the Staphylococcus, Pseudomonas bacteria in particular.
Pseudomonas!
Nobody likes Pseudomonas, right?
I mean, Courtney, it's all fun and games until someone gets a Pseudomonas, right?
And probably it wasn't fun and games to begin with, but yeah, it's definitely not with Pseudomonas. So I hear you 100%. So yeah, that would be it. Now, just as an aside, the microcurrent wound dressing, you know, it uses anions and ions to try to stimulate using the electrical currents of wound healing without being perceived by the patient, which is kind of cool too. But I probably would choose the silver because of its low toxicity. Let's jump right to 10 days post-op. Take a look at this picture right here. All right. First and foremost, type 3 collagen is going to predominate in granulation tissue. Then it progresses to type 1, which is, you know, the predominant collagen type in skin, right? And then what's responsible for that contraction, and this is my favorite cell type in all wounds, is the myofibroblast. It basically tightens that wound and helps it contract, which is really beautiful. I know. If you saw myofibroblast up close, you would think it's super, super cute as well. And then finally, yes, I am a fan, particularly on granulation tissue, of that silver impregnated wound matrix because there's likely a biofilm or these sessile bacteria that are just sitting there that, you know, probably predominate in many wounds. Even those that look clean, there may be a biofilm or bacterial component, and the silver, because it's low toxicity, it will just help prevent that biofilm formation. So I would say those would be the main 3.
That's incredible. To recognize at the cellular level what's going on, I think, is what helps us make the right choices for patients when we're looking at topical wound care, especially with something as complicated as a neoplastic tumor that is on something like a digit with not enough real estate, as we say, to close the wound by primary intention. So, okay, so that's excellent. So now what happened to Zelda?
Let's jump right to 3 weeks post-op. Take a look at these pictures. Right? Now, we're seeing everything's covered now. I know, right? That's really nice. You can see, listen, the oohs and ahs for granulation tissue. I'm sure granulation tissue gets that all the time, you know? It gets the oohs and the ahs.
I mean, it's just a regular Saturday night for granulation.
Exactly. But the reality is this. You can see evidence of epithelialization. You can see evidence of that granulation tissue. This is really good stuff. And it basically means, hey, this wound is healing, it's healing fast, and it has a great environment. There's been a tremendous amount of wound contraction there, a tremendous amount of healing there. And so because there's so much healing, there's contraction, you still see that little triangle of granulation tissue. So what do you do now? Do you just let this thing air out and let it scab up? Or do you let, as they say back in the day, let the air hit it? Or what would be your preferred option right now at this stage of wound healing?
Oh, Dr. Courtney, I don't even need to give folks at home a choice, because we all know that you should not let that wound air out overnight, as Grandma used to tell us, right? Take the Band-Aid off and let it air out overnight. No. I want to maintain an ideal environment.
You're right, Jen. You should never let it air out.
My topical of choice, I guess, at this point is probably going to be, I'm going to maintain that the silver impregnated matrix, the nanotech, because I can see through it, like you said, which I didn't even think about that, but that's excellent. How many times am I looking at a bandage wishing I had some kind of bandage x-ray vision so I didn't have to take it off? So I love that. And then, you know what? You know what wasn't on there is what's happening with Zelda? Is she trying to lick it? Is she trying to eat it? Like, what's happening?
Yeah, 100%. 100%. I totally agree. Epithelialization, I'd cover it because we're still technically in that proliferative phase. And I know the maturation phase and proliferative phase, they kind of overlap. It's not like a clear defined border, but you're right. So I would do that. And of course, I would cover the wound. So a healthy wound to provide that environment needs to be covered so epithelialization could actually occur faster. And then, Jen, let's just do this. Let's just celebrate at 4 weeks post-op, because take a look at these pictures of Zelda 4 weeks post-op. Pretty impressive stuff, right? Pretty impressive stuff.
I know.
So
I love it. She is ready to resume her normal schedule of pedicures. That's all I'm saying, right?
But fortunately, these parents, they're so good. These pet parents are so good because they actually kept her in an e-collar for several weeks just to protect that delicate epithelium, because we know that a scar is actually 15% or 20% weaker than normal tissue. So it'll always be that way. So it's so important to protect that delicate epithelium. So I'm so happy for Zelda. She turned out okay, healed super fast, all because we had a favorable wound environment.
That's right. That's right. Good on you, Dr. Campbell. And thanks for bringing that to light, because the topical care for a wound is something of interest to me. Living on a farm, dealing with different creatures who show up with all kinds of weird things, and they do happen overnight. So I have a challenge for you, Dr. Campbell. You ready?
Oh, I'm born ready. Let's do it.
So an 8-year-old female spayed Pomeranian named Sugar. Do you like that? Sugar?
Of course.
So Sugar had a 5-month history of a progressive crusting that started on her limbs, her forelimbs, and then it moved up to her face. Bless her heart, poor Sugar. And there's 2 other pets at home. They happen to be cats. Of course, they're not affected, and they're staying far away from Sugar. The referring veterinarian did a DTM culture, as any good doctor would do, because I'm sorry, crusting screams fungus at me. Does it scream fungus at you?
Yeah, anything crusty sounds like it could have a fungal component.
The crustiness has progressed from the limbs up to the face. Oh, poor Sugar. She is not ready for a close-up now. And so, Dr. Campbell, what would be your next step if Sugar was your patient?
So, I'd say let's give some choices.
Think about what you would do. We'll see you on the other side. Dr. Campbell, what would you do?
I would have started out with a cytology, but I'm sure there's probably a better answer.
Well, as you know, in practice, there's never a better answer or a wrong answer or a right answer. There just is what happened.
Right, but there's definitely some wrong answers, yes.
Okay, well, I wouldn't debride the crustiness. No, that's true. So a biopsy, these folks, I would have gone with cytology myself because it's less invasive, and I think cytology is a radically underutilized tool in dermatology cases, as my friends, the derm folks, have said. And so I would have gone with cytology as well. However, in this case, they skipped cytology. They did not pass go. They did not collect $200. Well, I don't know if they collected $200, but they did the biopsy. All right. So the biopsy came back as lymphocytic interface dermatitis and a pyogranulomatous dermatitis adenitis.
Well, I saw that tremendous immune response from the lymphocytic cells, and I thought, okay, clearly something else is going on here. I'm going to say I'm suspecting something autoimmune.
Ooh, good on you, Dr. Campbell. But in reality, 5 months of little to no response and progressing lesions moving up from the limbs to the muzzle with a DTN negative culture, which we know could be iffy. In reality, there was no response. Sugar had no response to lime sulfur, terbinafine, or Simplicef administration. So at this point, she's not on anything because she's been on stuff for 3 or 4 months. None of it worked. Lesions continue to progress. And so there's a new symptom. So when she comes back for a recheck, because her owner's not giving up, because she loved her little sugar, there is depigmentation and swelling of the nasal planum.
Yeah, that has mucocutaneous junction written all over it. Once I hear the lymphocytic, plastocytic, and I hear nasal planum, am I heading in the right direction there?
Yes, 100%, 1,000%. But I got to tell you, treating something that I suspect to be autoimmune in origin, that is something that is a little bit intimidating to me, and maybe intimidating to other practitioners. I mean, I don't know if it's intimidating to Dr. Courtney Campbell.
No, it's literally it is. I'm agreeing right with you. These are tough cases.
Here on Rapid Rounds, you know what we can do when we feel like we're getting a little bit far afield with some crazy stuff in the clinic, don't you?
Absolutely. I say let's talk to a specialist. I'd say let's get that stat chat.
Stat chat!
Thank you so much, Dr. Jen and Dr. Courtney, for having me on this stat chat. I'm Dr. Ashley Bourgeois. I'm a board-certified veterinary dermatologist and also present cases on social media under the Derm Vet. So something really interesting to note about this case's history is the fact that repetitive diagnostics were done and came back inconclusive. Cytology is something you definitely want to do on all of these cases because secondary infection can pop up at any time and the skin is forever changing. We know that sugar was getting progressively worse despite several different medications, including antifungals, because the biopsy came back as potentially dermatophytosis, so it wasn't conclusive. Getting inconclusive biopsies can be really frustrating, but it also helps us rule other things out. When we see depigmentation of the nasal planum and such an ulcerative feature to the skin, certainly neoplastic and autoimmune would be 2 categories we'd be very worried about. So the likelihood that this was neoplastic was probably quite low since the biopsy results came back inconclusive. So in this case, we did repeat a cytology. We'll do cytology in almost every dermatology case every time they're in the clinic. And we saw an excessive amount of cocci bacteria. And there was concern of resistance because sugar had already not responded to several different antibiotics. So when we saw there was a lot of infection, a culture and sensitivity was collected so we could identify exactly which antibiotic should be used to eradicate the infection. And then based on the depigmentation and the severity of the lesions, repeat biopsies were taken. The samples were then sent to a specialized dermatopathologist so we could increase the chances of getting a definitive diagnosis. So the culture and sensitivity results came back with the methicillin-sensitive Staph pseudointermedius, and we were able to successfully treat the secondary infection with clindamycin. And we did get a diagnosis on our biopsy results this time. The diagnosis came back as vasculitis or ischemic dermatopathy. So we had a feeling it might be autoimmune, but weren't exactly sure it was going to be vasculitis. So very happy that we biopsied and did several different areas so we could get an answer this time. For the vasculitis, we started pentoxifylline at 20 mg per kg twice a day, and then methylprednisolone at autoimmune doses. Our goal is to taper the methylprednisolone so we can just rely on the pentoxifylline long term, because pentoxifylline is very safe and the hallmark treatment for this disease process. I'm happy to report that Sugar is doing really well. She is tapering off her methylprednisolone, and we hope to discontinue that soon and just maintain pentoxifylline lifelong. Her ulcers have healed up, and the owner reports she is much more energetic at home and feeling great. Once we got the diagnosis, we dug a little deeper into the history and did see that Sugar had received vaccinations about 3 months before the lesions occurred. Of course, there were other preventions and medications that were given that time as well. So we don't know for sure the cause of the vasculitis or ischemic dermatopathy, but we will make sure to advise avoiding vaccines in the future, as this can trigger the disease process. If we can't avoid vaccines, we want to minimize them the best that we can. So Sugar's case shows us the importance of repeating tests if the results we get just don't feel right. Biopsies are something that should be taken from several different locations and definitely sent to a specialized dermatopathologist in complicated cases. Vasculitis is not the most common autoimmune disease we see, but it can look like several different things. We usually see the ear tips and the concave portion of the pinnae affected, but you can get diffuse cases like Sugar, where you have ulcerative lesions covering the body or the tip of the tail, the claw folds. So we definitely want to rebiopsy these cases if we just aren't comfortable with the results we have. If you find cases like Sugar's interesting, then I really encourage you to check me out on social media. Follow @TheDermVet. I like to put up diagnostic tips and fun cases that you guys can implement in your clinical practice.
Wow, what an incredible stat chat from Dr. Ashley Bourgeois, the Derm Vet.
The Derm Vet definitely took care of business. It was an excellent stat chat. And this is why we have the stat chats, to hear from excellent doctors like her.
So we hope you've enjoyed this edition of Rapid Rounds, and we hope to see you again when we talk about our next curious case on vet candies.
Rapid Rounds.